We're going to move on to the next talk. I'm just going to talk briefly about how we changed from a telehealth point of view, from our previous experience to where we are right now, and a little bit about the artificial intelligence, how we can use. So I'm a invasive non-interventional cardiologist, mainly specializing in heart failure and transplant. So we had a really good meeting with AAPI with about 600 people in Atlanta with American Association of Physicians of Indian Origin. So that's when actually Dr. Srinivas Kumar called and they said, we're doing this TCT. Can we put together some AAPI sessions? So that's how it came up. But when we are doing this telehealth, I think I just wanted to update my experience with telehealth. And we co-founded a company called eGlobal Doctors and how we used our knowledge with the telehealth to help in this kind of environment. If you ask me a year ago, my telehealth knowledge was zero. I didn't see any patients with the telehealth in the office. But since the pandemic started in March, we started seeing drifting down of the patients going down every month in March and April just because of the fear, and we didn't know what to do. And we were somewhat scared about how to see the patients in the office because we didn't know all the data. So that's when we started looking at different options for the telehealth. And then we started looking at, we used FaceTime, we used WhatsApp, we used DoxyMe, we used the Doximity. There's so many platforms we tried out and some of the newer platforms, and then we started using it backline. So ultimately we started seeing about 10 to 15 patients per day. But as the time progresses, I think as we knew more about the pandemic, and we started seeing patients again in the office slowly from June, July onwards. We still see about maybe 10 to 15 patients per day in our practice of 15 cardiologists, but telehealth has been slowly going down in the office practice. But when the second wave hit India, physicians of Indian origin especially were very concerned with so many more patients going overwhelmingly increasing numbers, and the doctors are not able to provide the services, and there was an oxygen shortage. So our American Association of Physicians of Indian Origin, at the time, President Dr. Sudhakar Janalagada took the initiative to support the Indian patients in whatever way we can. So with one email, we raised about $5 million within a span of 2 weeks. And at the same time, Seva International, which is a nonprofit organization, both in India and the United States, also raised over 15 million for this cause. And then at the time, we also wanted to do some counseling and whatever the physician force can help Indian patients at the time. So we started thinking about how we can help Indian patients through our physician force. So API asked us as eGlobal Doctors, which is our new telehealth platform. This is our platform. We were trying to use it as a commercial platform over the last 1 year, started by about 5 physicians and 2 IT professionals who were doing beta testing at the time to start the commercial way of connecting globally physicians and the patients anywhere to get the exchange of ideas and the exchange of the treatment options. Somebody from India can come here for a treatment, or from somebody from here can go back to India for a treatment. So that we were connecting the whole globe with the doctors from Australia and New Zealand. So when API was looking for a telehealth platform for connecting Indian patients to counsel by the physicians from anywhere, so we came forward along with the 2 other telehealth platforms and started asking the volunteer physicians to come in and help with the Indian COVID situation. Amazingly, within 1 week, over 250 physicians, including some American physicians, came forward, registered with our service, and doing the telehealth counseling services to the Indian patients. So through the platform, we provide the malpractice insurance. So we have the registration process, simple process, so that it was easy. And we asked our IT people to go through and see, just to make it more simpler for people to join as a Zoom call. So our main goal was to connect the physicians and do the secondary consultations from different parts of the world. And also there are sometimes the multiple consultations may be needed. If somebody has a cardiomyopathy with ejection fraction of 10% and anywhere in the world, and if they want to get the best out of their situation, talk to the electrophysiologist, interventional cardiologist, heart failure cardiologist, and cardiothoracic surgeon all at the same time from anywhere in the world. And one good thing with this telehealth is we can have the families from anywhere. If a patient is in Australia, but the family, one is in UK, one is in India, one is in US, we all can be at the same time, the same consultation so that as a family, we can participate in the consultations at the same time. So that was the beauty of these telehealth consultations. So that was our goal. But I think then we started looking at how to improve the COVID-19 situation. So this is where our team came up with a Zoom link. People come to eGlobal Doctors website, and then they fill out a form developed by one of the CDC scientists, and then join the meeting. It was amazing that so many doctors who are radiologists, ophthalmologists, the cardiologists who don't treat regularly in the office. So we came together, and about 250 people every day. We would have a session of about 20 to 30 minutes before we started by a critical care specialist, so that he would educate us. Okay, this is what we do. These are the things you need to do. The CRPR, when to use the steroids, and how to avoid the blood sugar checkings and all that. Give a 20-minute to 30-minute talk, and then if we are not sure, the doctors would join in one of the rooms with the experienced physicians, with the critical care doctors, and an individual breakout rooms. We had 100 volunteer group. They would go take a patient into the breakout room and then get the doctor who can speak their language and into the same breakout room. And the newer doctors who are coming in would join them for 1 or 2 days so that they feel comfortable treating the outpatient, the COVID. Mainly the counseling, I won't say treatment, but mostly counseling. Our goal was to relieve the anxiety of these patients who are quarantined in their own homes and not able to know what to do. And they were scared about what is happening. And also educate them what to look for when the saturation goes down, what to do, what to look for the heart rate point of view, when to go to the hospital. So all these doctors, they were working their daily jobs and started at 8:30 in the evening and went on until 1 o'clock at night for 4 to 5 hours every day. The few days we saw 25 to 30 patients all over India. So this is one of the CDC scientist forms, which people give the information, they fill it out, and then go to the outcomes, what to do, how the proning is, what the pulse ox is. So there are a lot of education. This was more an education counseling session more than the treatment. We also had Indian doctors joined our team so that if somebody needs a treatment, so they would go and take care of the patient locally with what the treatment is. And as the time passed, I think we realized that there were a lot of rural areas patients were having issues with the COVID and not able to get onto the websites like what we were doing. So we started going the counseling with the phone consultation. So the people send an email or a phone call, and our volunteers will connect with the doctors, and then we expanded onto the daytime so that we can see more patients. So over the last 3 months' time, our volunteer physicians have seen over 2,200 patients, and then from all over the world, mainly from India. So as the time passed, I think non-physician healthcare workers joined our team, physical therapists, occupational therapists. They wanted to help the cause, and they started helping with the post-COVID syndrome. And also we're starting a group with the help of the Intuit Foundation, and then also Stryker and the Stanford University, where we can help repair the equipment, the ventilators, the CPAP machines, BiPAP machines, ECMO machines, which are being donated, but they're out of the warranty. But these biomedical engineers and the technicians are willing to go through the hospitals wherever they need, so they can come on like the same thing like what we're doing with the patients, so they can do it for free and extend the warranty. And this is there are about 1,100 to 1,200 biomedical engineers and technicians are willing to participate in that. We are finalizing that so that we can have these machines to better use in the rural areas of India and anywhere. And also we had a lot of webinars and helping the critical care doctors in small towns and rural areas who don't have the enough expertise to take care of these the patients with COVID. So within a short span of time, like 2 months, I think there was so many articles written all over, like both in India as well as, there was an article in Wall Street Journal about the eGlobal doctors, on CNN, on Fox 5. There was like amazing response to show the gratitude for our experience and taking care of our Indian patients. So that was very gratifying experience for all the physicians. And now the numbers have gone down. So we're only seeing maybe 1 or 2 patients per day. Now we're doing more on a case-by-case basis. But people are on WhatsApps and eager to help. If there is anybody comes up saying that there is a patient need to be seen, we are seeing right away. And then just to switch gears a little bit about artificial intelligence and what we're doing with artificial intelligence in the telehealth. So we can use the artificial intelligence, which came a long way compared with 5 years ago, with what versus now, with the tele-assessment, with the diagnostics, with the interactions and the monitoring. So we have enough algorithms with the artificial intelligence, with which will help us to take care of our sorry. Sorry. Okay. I'm just going to. So connecting the patients with the different languages at the same time, also helping when the discharge comes. I think people can look at from different areas of the country and help the post-COVID in the AI. I'm not an expert in AI, so but I think looking through all the literature recently, especially with oncology and dermatology, there was a recent study which showed that there is a neural network algorithm which outperformed 58 dermatologists in the diagnosis of melanoma with a similar promise in the breast cancer and cervical cancer. I think with the artificial intelligence, I think we should be able to go long way in the future with the telehealth and artificial intelligence. I think our practice will be a lot different 10, 15 years down the road than where we are. There's just some social and ethical considerations. So I think with the AI, we just want to make sure that all the rural, remote areas, as well as underdeveloped countries will be well represented. And then also monitoring the technology with the extremely ill or the aged patients may not have enough technology to use it. With our expertise with the AI, we may be able to help them a lot better. Then people must come first. The focus should be to use the tools to improve the outcomes and reduce our provider burnout by using these artificial intelligence and other means. Thank you. I think that's just more my experience. I think the telehealth is only going to get more and more as the time passes. I think we're looking forward to using the AI in the telehealth to make the quality of care better for the people all over the country and the world. Thank you. Any questions or comments about the telehealth and what we can do?
As far as AI is concerned, Mayo Clinic has already started doing EKGs by AI. So AI has turned out to be a better diagnostic, quote unquote, way of reading EKGs than the physicians. It's 100% accurate. So at Mayo Clinic, the doctors don't read EKGs anymore. And the next thing they're doing is echoes. So with AI, artificial intelligence, echoes are going to be read by computers, and I think the doctors might not be reading them in a very short span of time.
Yeah, I agree. I think there is so much more happening. Also with the studies, I think probably Dr. Grimes may be able to comment. We used to have so much data, we had to go manually. With artificial intelligence, I think we can do all that. I think we can get a lot more outcomes, a lot easier than what we used to do before.
Yeah, I think that's a very important point to bring up, Dr. Gangasani, that, if you can get the computer read or have an algorithm to talk about the EKG, that would be very beneficial because there's a lot of inter-observer variability. And the same thing with echo, particularly the wall motion on echo. You might not see the endocardium that well. So artificial intelligence, I think, would be very, very important. And then the final thing, at least in this country, many of us would be reluctant to sign on to give advice because of the medical malpractice issues. And so if you had some standardized algorithms through artificial intelligence, I think that would make all of us feel more comfortable.
Great point.
Dr. Gangasani, quickly, there's a lot of information that you're likely to gather. I don't like to use the word wealth in the current environment. You're going to get a lot of wealth of information from the thing. Obviously, once you start analyzing it, it's going to be very, very complex.
Once the presentation starts.
Are you following these patients that you have counsel? Is there a follow-up evaluation? Respond quickly.
We followed up with all the patients as we go by, and we have volunteers following up on these patients. So some of the patients were actually coming every day just to update the doctor who they were seeing. So actually they had a bondage of the specific doctor. They would ask for the specific doctor, but we also had volunteers followed up on the patients. And some people come in after a week, just to come by and said, give them the numbers, like what the D-dimer was, or if there is or the IL-6 number was, what the CT showed. So there were a lot of follow-ups, and it was, especially in the rural areas, we're doing a lot more follow-ups, make sure that if somebody needed to go to the hospital, we wanted to make sure that one in Andhra Pradesh, we had to send a patient, call the EMS locally to send them to the elderly couple to the hospital. They were at home, but their saturations were going down. So I think it was follow-ups were done.